talking to us.
If you...
All right. Hello, it's Emily Kirkpatrick here, SA&NT GP Liaison. We're just having a few technical issues, no surprise. Thank you for the hellos coming in, so hopefully you can hear us okay. As you can see, we've jumped straight to the presentation because of our technical issues. So we're going to start first of all with Dr. Tom Dodd, but I'll just introduce who's here and we'll just start with a welcome to country as well. So thank you so much for joining us. This is now week 6 of our webinars. And I'd like to acknowledge the traditional owners of the land in which we're meeting here this evening, wherever that may be for you tonight. We're here on Kaurna land at the AMA SA offices, and we thank those elders who have come before us and those who may be present among us as well for all they've done to care for the land that we're on today. So I'll just introduce who's here at the AMA offices today. We've got Dr. Chris Moy, AMA SA President, Dr. Tom Dodd, SA Pathology Clinical Services Director, Dr. Louise Fudd, CDCB Director. We're very excited to have Dr. Santosh Daniel here today, who is an ID physician at Flinders down at Salem. We've got Dr. Jenny Gould here, who is wearing 2 hats this evening. So she's wearing her antenatal shared care hat to give us a bit of an update on COVID in that space, and also her GP assessment clinical lead hat for COVID as well. And then myself here, Emily Kirkpatrick, Deputy Chair, RACGP and SA Health Clinical Liaison for COVID. So we'll start with Tom, if that's right. And just before you start, Tom, I wanted to say big congratulations today. It was announced that SA Pathology will not be privatised and will be staying as a government organisation, which we are so thrilled to hear about. So I think that's a real testament to the huge amount of work you've done within your organisation and your response to COVID. So thanks, Tom.
Thank you, Emily. Good evening, everyone. I thought I'd just give you a quick update on how the testing's tracking around the state. So this is a graph showing the sort of testing by percentage population for each of the states. South Australia is the line at the top, and what you can notice right at the last sort of 3 or 4 dots there on the graph is this kick up in testing, and that correlates with the so-called blitz, or really the relaxation in testing criteria. So as you'd all know, we're now essentially testing anyone with upper respiratory type symptoms. And since that started effectively last Thursday, we've now done 10,000 swabs, which is actually very, very impressive. So in terms of SA Pathology, few things that I just wanted to mention to this group. And you'd be aware there's now this change in the way bookings are being arranged to the SA Pathology drive-through collection centres. Now we're just receiving faxes directly from you folks, and we're meant to ring through and book the time for your patients to come and visit us. That, of course, coincided with a huge upturn in demand, and so I know we haven't been quite as efficient as we should have in ringing all your patients as quickly as possible, but I have got a whole lot of more resources doing that, so I'm hoping that's now working a lot better than it was this time last week. The other important thing, I think, is the provision of the negative results to patients. So we've got a partnership with Personified Care, which is one of these medical IT companies based here in Adelaide. And essentially it will allow negative results to be SMS'd to patients. It's a 2-step process. Patients are invited to register initially, and then when their result comes through a negative result, then that will be sent as a text to the patient. It also includes a little bit of advice to contact you as GPs around what needs to happen for follow-up, because a negative result's important, but there's got to be some clinical context around that. For some patients, you know, there won't be much to do, but for some where they're still in isolation, that the interpretation of that obviously requires some clinical advice. The other thing that's we're working on vigorously is having a consolidated process to email any pathology request forms for those of you who are working from home or otherwise and need to send through request forms for blood work, etc. Very shortly we'll have a single email point you'll be able to email request forms through to. It's in sort of a trial phase at the moment, and I'm told it's progressing well. And finally, we are very close to having a larger domiciliary service to be able to go and see patients out in their homes, or if need be, on a bigger scale for nursing homes and so forth, if lots of patients need to be swabbed. So I anticipate to be able to roll that out without the requirement for a contact with Louise's CDCB team shortly. And that's all I've got for you folks this evening.
Thanks, Tom. We've had a question come in around, do they need to be invited to register to get the negative SMS result, or is it just automatically if someone has a mobile phone number on the request form?
So what happens is the patient will receive an initial invitation to register effectively through this Personify Care. None of their clinical information is held by Personify. We use their name, date of birth, and I think mobile phone number to sort of ensure we've got the right patient. And that's the first step. And the second step, once the results validated, then there's an SMS sent to them, and then they log in, and then the negative results given to them. So it passes all these sort of security and privacy regulations, and it's been heavily vetted by Digital Health. So I'm sure they've done a very thorough job.
Good. And we trialled it as well, Danny and I, when Danny was the other half of this team. We did trial it, and I know Danny is in Melbourne now and is listening to this webinar, so he'll have to put up with my comments throughout about that. We've had another question that's come through as well around notification of positive results, and I don't know whether you want to talk about this, Tom or Louise, but if a patient does have a positive result come back and they did sign up for the Personify Care option negative result, will they get anything at all through the system or nothing at all?
So there's an inbuilt lag of 24 hours between the time that the result would be available and us contacting them by SMS that there's a negative result, to allow an opportunity for the positives to be identified. And of course, happily, fortunately, there are very few. So for you folks to be notified and contact your patient. So we've been about that very deliberately.
Yep. And any plans at all from your end, Louise, at CDCB? Will it still be a phone call that the patient would get if they're positive?
Yeah, so as soon as we get that result, and we're pretty quick because then we get an email from SA Pathology when there's a positive. So as soon as we get a positive, we ring that person up so that they make sure they know their result. And then from that is the sort of two arms of the response. So one, the clinical arm, and then the public health arm as well, to get that person interviewed so the contact tracing can occur.
It's all very interesting, isn't it? I mean, we're moving a lot to digital notification now. Do you think that we've had a couple of questions about this, Tom? Do you think there's any moving towards other results coming out in this method at all? Is that something that you think we'd be looking at in the future?
I'm sure there is a whole lot of things we're going to do which will be far better and far more efficient. And I think this will help with all sorts of things.
Now, I'm just putting up Louise's, sorry. Chris, I'm exposing your computer to the world. So just hand over to now to Dr. Louise Clark, CDCB Director, to give us a bit of an update of where things are at in the state.
Yes, so just a brief update on the case numbers. This is as of last night, worldwide, 2 million cases, well, almost 2.5 million cases, which is huge. I did it last time, 2 weeks ago, it was 1 million cases. It's gone up that many in 2 weeks. Over 170,000 deaths. Most of those deaths the majority of deaths have been in those countries listed. So in Italy, USA, Italy, Spain and France. And there's a case fatality rate at the moment of approximately 6.8. Just a map of where it's occurring, and as I've said multiple times in the past, the number of cases that are detected depends on the number of the tests that are undertaken. So there will be fewer cases detected in some countries just because they have a less extensive testing regime. And so you can see large numbers of cases are in, particularly in Europe and also in North America, in the US. And this is the curve of the number of cases from when that country first had their first 100 cases. And you can see Australia's there in the red in the middle, and that we did have a bit of a steep curve initially, but we have really flattened out our curve over the past couple of weeks, such that it's minimal increase in the number of cases on that. But it is a log scale, but it is much flatter than some of the other countries. And if you look at the US, it just keeps on going up, and same with a lot of the European countries. And it's also interesting to see Japan, that is just keeps on going up. Whereas, and then you have South Korea that is managed to keep theirs fairly flat as well now. Looking at the epidemic curve worldwide, still large numbers of cases in Europe and the Americas. And what was occurring in China earlier now looks very small. This is the number of cases in Australia. This is as of last night, over 6,500 cases. And still the majority of cases are overseas acquired, but there are quite a few that are also contact of a known case, so a locally acquired but a known contact. And again, this is the testing rate in each of the states will affect the numbers that are detected. And you can look also there, the increase over the past week, that Tasmania's had quite an increase there, as has given the size of their state. And we do know there's that outbreak occurring in the north part of Tasmania. Looking at the epidemic curve here, you can see we've had a very dramatic decrease in the number of cases that we're getting each day compared with what we were having, say, a month ago, which I think is very impressive. And then looking at South Australia, you can see we've had so far 437 cases, 2 reported. This is the data as from yesterday. 2 reported yesterday, and just 1 reported today. Most of our cases are overseas acquired, so almost 300 overseas acquired, with 125 there, a contact of a known case. And then there's our epi curve, so still small numbers occurring there, and as I just said, most of them are overseas acquired, but we do have a number that are locally acquired where they're a close contact of a confirmed case. Looking at the age and sex distribution, minimal numbers in young people in the 0 to 9 age group, and in the those less than 20. And we do know that does seem to be less disease in the children, but whether that is because of testing or whether it's the disease just doesn't really occur in children, it's not totally clear. But yes, definitely we mirror what's happening worldwide, that there's less cases in the younger people, well, in children. And this is just the criteria that we have for testing. This is just the background testing, but then there is always also we do have the blitz occurring at the moment. So pretty much anyone who has a fever or an acute respiratory infection, as assessed by a doctor, is able to get tested at the moment. And that testing blitz is due to finish at the end of April. And yeah, that's just about the testing blitz. And it's a notifiable condition, and it can be notified online. And just reminding you about infection control, because it's the best way to stop this, as well as the isolation and quarantine and all the border restrictions and that we have in place.
Thanks, Louise, for that update. So we're doing very well in this state. That's the key message, is that right?
I think so, but I might be biased.
Let's ask Louise, one of the questions that have been out there is about testing, just young people getting them tested. But the question was almost put by the minister, that just test them, asymptomatically. That was almost what it's applied, but that's not by the criteria at the moment. Was that what was implied by what he said? Because I've seen the media and it almost sounds like testing young people just to see whether they've got it.
I'm not aware of that. The recommendation as far as is still you need to be.
You need to have symptoms.
Symptoms. Yeah.
No. It's because that's not really the whole thought about this sentinel testing, which is out there at the moment. I mean, we're going to the next step, which is anybody's got symptoms, but not technically by what they're saying by the sentinel testing, which I actually don't know what that means at this stage. Yeah,
I mean, there has been discussion about whether we would do asymptomatic testing and that type of thing, but at the moment, the only group that's being recommended in is Qantas workers, as far as getting control of that outbreak.
And I suppose the interesting thing is we've tested now effectively 10,000 people who have symptoms who are all essentially negative. I think all the ones that have been reported in the last 2 or 3 days can be tracked back to some other initial contact.
Yes.
And so the chances then of moving to a broader asymptomatic population to pick up would seem to be even less likely other than selected groups. And I think even our Qantas group, which we've largely swabbed, also we haven't really picked up anything that's not surprising, the sort of broadest testing.
Yes, I agree with Tom. I mean, we've tested so many people and we just haven't detected unexpected cases, which is really, really encouraging. I mean, it's also always possible that we just haven't tested the right people, but it is, I mean, it is pretty encouraging when we've tested so many and we haven't had, I mean, it's only been going for less than a week, the Blitz, but we just haven't picked up ones that were, how did that person get it sort of cases, which is very encouraging.
5% of the Barossa local government area have been swabbed now, population there. So that's pretty significant.
If I can just add something, when we call somebody asymptomatic, at that point in time, they might be asymptomatic, but whether those patients are followed up, because some of them can be positive 24 to 48 hours before they develop symptoms. So when you look at the world literature, you find that many of them, when they're followed up, they had mild symptoms. So this notion of completely asymptomatic super spreaders, actually, there's not much evidence for that. So
I actually might just say something in response to that. There has been a change that I probably should have highlighted. There's been an updated in the Communicable Disease Network Australia series of national guidelines that we have now changed the criteria for following up as far as cases are concerned, as far as their contacts, to 48 hours before the symptoms commenced.
Yes, that's quite interesting. Do you know why that change has come about? Is it just that we have more data on that now?
Yeah, just there's more information. And in fact, Australia was quite unusual that we had that 24-hour period for a lot longer, as in that we were following up asymptomatic people as far as contacts for before a lot of other countries. But yeah, it's just more information is now available, and so that there's more evidence that there is some transmission in the 2 days before you develop symptoms.
And we had a question come through around, could the virus have changed so that this test is now not detecting it? Is there any evidence to that at all from an ID perspective or from pathology perspective?
The test is for a core gene of the virus, so I don't think it's a reliable screen. It's not looking for a very narrow segment of the genome. And apart from which, I mean, we're still getting positives anyway.
And another thing, as far as our testing and whether we're testing the right people, is we're not getting a whole lot of people turning up in hospital with severe disease, which you would expect if we were missing a large number of cases.
And that will be the same. If you have going back to that asymptomatic current in the community, if that is happening, first of all, we should have picked up more in the testing. Secondly, we should have had this epidemic going on. We should have kept getting more positives without any sort of epidemiological sort of contacts. So that's not happening, which again shows that there is no, there's not a pool of asymptomatic people going around and spreading.
Yeah, that is very reassuring. I mean, the other thing that's of course been announced is the new tracking app, and we've had a question around that as well. And I guess, what's the understanding? I don't really know a lot about the tracking app, I must admit. But is it designed to be tracking positive patients, Louise, or is it designed for? Do you know about that, or is it designed for any person in the community who's been identified as someone to follow?
The Commonwealth app?
Yes.
I don't know that much about it.
No,
my understanding, it's not a GPS.
Yes.
It's not a GPS one, so it doesn't record like
So not like the
some of the naughty
one.
stuff
Yeah,
that's
yeah.
been going on with some of the Google and stuff. So basically, I understand it's Bluetooth technology, and it's based on the fact that it records kind of whether you've been close to somebody that's actually been to another. They've got a Bluetooth device that actually can connect you, so you can then go retrospectively to see whether you were actually close to somebody who had contact at a certain time with an individual that had been proven positive. So it's stored on the actual device itself. So it's actually, the idea of it is actually, it's a self-contained thing to try and get away from the privacy stuff. And it's only used once you've actually become positive.
Right. Okay. So, but I guess it's reliant on people actually using it who are testing positive as well. If it's
They have to be approved.
Yes.
Well, at this stage, it's going to be voluntary.
Yeah.
At least 40% of the population that is testing has to download that app for it to be functional.
Yeah.
But the whole point is contact tracing.
Sounds like a great initiative. Actually, just speaking about the contact tracing, the other thing I think we mentioned as well from the song, and was around the changes around 15 minutes of exposure over 7 days. I think we put that out in our GP update, because we've had a few people say the cumulative effect now of the 15 minutes exposure, not just on one point in time. So that makes it really difficult. I was thinking about this, it makes it really difficult if you've got a family member who's been diagnosed. How would you limit less than 15 minutes in your household, just from slight incidental exposure? And I guess that's one of the big reasons why we should be really encouraging positive patients to not be at home in the household with others, and being really onto that. I think that's probably, would you suggest that as well, Louise?
Oh, definitely. We've had household transmissions, and you wonder whether maybe they could have been prevented if those people hadn't been.
So Danny's actually, the app will calculate the 15 minutes over last week.
That's wise. You've downloaded it, Danny, for your trip.
So, yes, we would, when we get new cases, strongly encourage them to not stay at home with their family.
Can I just take this opportunity to advertise the caravan park that we have on Sturt Road? So we have, you would have known that a few weeks ago, the Minister Hunt had come and mentioned that this caravan park is available. So we have had quite a few patients. What happens is that they say, no, we want to isolate at home. Then by the time a 14-day quarantine period for the rest of the family is almost finishing, the next member of the family becomes infected.
That's right.
And then there's another. So now we are, once the CDCB has interviewed them, if they are from the Salem catchment area, when we see them, we then flag and say, you're a potential candidate who can move to the caravan park and spare the rest of the family, the trouble. Otherwise, each time somebody gets infected, the person who is not infected gets another 14 days.
That's right.
So you have to, and South Korea's model and how South Korea, Hong Kong, and Taiwan, 3 success stories, had been mainly testing, isolating. And that's the only thing that works.
Is it being used much, the caravan park, the Marion caravan
We
park?
had at one point in time 5 patients. That was the highest, but we've got 60 cabins available there. It's a 7-acre property, state of art, and it is very close to Flinders. So if at all you need a a medical sort of review, we can just come there and have a look at the patients.
That's fantastic.
So our nurses, and it's easier for hospital at home because instead of them getting in their car and going from one house to another where they have to don and doff PPE, they can just go to the caravan park, go to multiple cabins, and less PPE, less danger for them also. The nurses, every time you doff, that's where the worry is. So it's a great model, just like now you've got hotels for people who have come from overseas. And the fact is that these caravan parks are such that, you have such a good environment around, rather than just getting stuck in a hotel room or in your own.
That's great. It's a fantastic initiative, and I know I've given out your details, not your mobile number, but I've given out your details, Santos, to a number of people who've called asking for specific ID advice, and you're quite happy to receive calls through Switch. Is that right, at Flinders? Yeah. And you've got a RMO as well, I think, assigned.
Yeah, we've got a dedicated RMO, and we've got a COVID phone, which is a deck phone in the office house, and then we've got a registrar or a consultant on call after hours.
That's fantastic. So I think that's really good advice if you are a bit stuck and you obviously go through your usual pathways with CDCB and the usual process with the GP assessment team, but keeping in mind that there's some great help at the end of the line.
So that's for the silent catchment.
For the silent, the silent, yes, that's right. But and we've got a similar service is being offered as well through Tarleton as well with the RA. But yes, always following the CDC pathway as well. I'm going to hand over now to Dr. Jenny Gould, who's going to give us a bit of an update on the GP assessment team and where all the numbers are at. Jenny.
Thank you. Hello, everyone. So having a look at, I just thought it might be of interest to let you know the number of patients that have come through our GP assessment team, which is a group of GPs who work out of GenWise. So we've done a total of 334 patients, which if we've got 437 to my maths, and my maths is not very good with all this homeschooling, it's been proven that I'm not very good, but I would say that's around 75% of them we've seen. So 275 we've done the initial risk assessment on. We've cleared 182 from their release them from isolation, and we've done 142 where we've followed them through the whole journey from the beginning to the end, and 40 patients that we've cleared but we didn't originally have come through our system for assessment at the start. So I think, we've that the process is working really quite well now, and we've keep on fine-tuning and tweaking that. But yes, our numbers are getting less. We're getting more clearances and less risk assessments to do. So did you want me to go on to the shared care?
I think we've had a few questions around shared care, and I think it'd be fantastic to hear where that's up to, Jenny, because that's obviously a big part of general practice is providing that care.
So yes, I will just put on my other hat, my GP shared care hat. So anything that you really want to know about the shared care program or any updates with COVID, our GP Partners Australia website, the shared care link, has got it all there. And as you know, that it's a program for women for low risk normal pregnancy. So what an ideal time to grow our shared care numbers, keep these healthy women out of our tertiary hospital centres. Leanne March is our fantastic programs manager, and I've put her contact details there because she is really the one-stop shop for everything you might want to know, and if she doesn't know, she will find it for you. So, and then there's two GP advisors, so myself and Michelle Emerson, who are happy to be contacted as well. This just shows you the numbers of shared care. This graph only goes up to 2016. But really you can see that certainly at the moment it's an ideal time, the sky's the limit. We really could keep building those numbers and keeping these healthy pregnant women outside of the hospital system. This just shows you the total number of GPs in the program, and it usually runs somewhere between about 600 to 700. And patients can find GPs in the shared care program by just logging onto the website, putting in postcodes or looking up GPs by name or practice. So there's lots of ways to identify shared care GPs. So that's a bit about shared care, but when we're looking specifically at dealing with COVID and pregnancy at the moment, I think there are quite a number of resources out there. So the Obstetric Shared Care website does a regular update, and they're all accessible on the GP Partners website. Leanne is great. She'll pull together the RACGP updates and any other updates that are around, so it all comes to be found in one place. This is just the last couple of days of newsletters that she's sent out, some samples of the information that is there. And I guess this is really just a quick summary slide of what's happening in shared care, and it's a far too busy slide, and it shows you I did not have a lot of time this afternoon, but it's mostly business as usual. And as I said, it's the perfect time for the shared care program because it reduces the number of visits to tertiary centres, and the RACGP guidelines clearly state what we need to do is reduce the amount of face-to-face contact with our vulnerable pregnant women, and one of the ways to do that is GPs. And the RACGP have guidelines which are updated daily, and you can access them through the website, but as in all circumstances, they're not applied uniformly across South Australia. So different centres are doing slightly different things. But overall, the focus is to reduce face-to-face as much as possible. The first visit at the hospital or at the GP surgery can largely be done through a teleconsult because it's mostly information gathering. And as we've talked about tonight, keeping the visits under 15 minutes if you need to do face-to-face is also appropriate. I mean, women can check a lot of these things at home. That does make consults much easier. You know, a lot of them have access to blood pressure machines. They're certainly able to monitor their fetal movements and their weight. And when you're doing a consult, you'd be wanting to check in about the movements, their sense of growth, you know, symptoms of preeclampsia, asking around domestic violence, mental health, which I think is becoming an increasing problem as people spend more and more time at home. The Women's and Children's has a fact information sheet for COVID, and I was going to put the link here, but I did not, but it's on the SA Health website.
I can send it out for you, Jenny.
Thank you. So the one thing that's probably somewhat different is screening for gestational diabetes. So we now offer screening in the at-risk group with early glucose tolerance testing and then the routine testing at 28 weeks. Now, the state guidelines for South Australia are that we are still going to stick with glucose tolerance testing as the first option, which isn't necessarily in keeping with other guidelines. NALHN are actually not doing that, and they're actually using a fasting BSL. So what is said is with early screening, try and do a glucose tolerance test as your first option. Hemoglobin A1C has really been proven before to be inadequate as a screening tool, but now we're perhaps suggesting we can use it if it's above 6.5. And then the 28-week screening is the same, a glucose tolerance test or fasting BSLs. And I think there are lots of other options. If women are worried about sitting in the collection centres, lots of the collection centres have made arrangements so that these women are not sitting out in a busy waiting room surrounded by coughing people. Is that correct, Tom?
That's right.
And I mean, and there have been cases where women who are extremely anxious have sat in their car and just come back in for the testing. The other thing that we can certainly do through the hospital settings, and you can probably do in general practice, is to set them up with a glucometer, and they can do a week of profiles, and that's probably at least as good, if not better, than a glucose tolerance test anyway. So there are ways around that. But if you're struggling with that, sing out and we can certainly help you. So I think that's pretty much my update.
Thanks, Jenny. We've had a question come through around the follow-up care. So, of course, after Bubba's been born, is home. Are the midwives still visiting those women? Because we've just had a question come through around it that the mum and the baby weren't visited afterwards because of COVID concerns. Is that an issue that you're aware of?
Yeah, so the visiting postnatally is different across the different tertiary centres anyway. The Lower McEwen certainly has a much more resource-intensive domiciliary visiting service postnatally, whereas women's and children's and Flinders, they just do a one-off visit generally, and then CAFs will do a visit. Now, if people are struggling or there's a premie or there's, you know, other issues, then there are more visits, but the routine is really just a one-off, and those visits are still occurring, but I think probably they're being screened, so the women that aren't necessarily needing a face-to-face, a lot of that can be done over the phone, and if they do need a visit, then that's arranged. But yeah, there is fairly limited visiting generally anyway. So again, another plug for our fabulous GPs. It's the one-stop shop to get all of your answers with your child that you're finding very difficult to settle or feed. Yeah.
Thank you. Thank you. So that's wonderful. If you have any questions at all, we're happy to redirect those. You can email me and I'll redirect them to you, Jenny, as well. We have sent out your details before, but just in case, very happy to take emails. Now, we've had so many questions come in for you, Santosh. Everyone's really interested to know more about the infectious status around COVID. So we'll start with one of the questions we've had is around the testing process. So we know that if you have a test done that doesn't, and it comes back positive, that doesn't necessarily equate to being infectious and contagious. Is that right? So this came in the context of through the clearance process that no swab was done, but the patient then became asymptomatic after about 72 hours after their 10 days from symptom onset. What's sort of your thoughts and discussion around the infectious status of that patient, even if they, you know, for instance, accidentally had a swab performed when they didn't need to have it as per the current criteria and it came back positive? What would you sort of advise with that, or what are your thoughts from an ID perspective?
It's a difficult question.
Yeah.
I think if the patient is symptomatic, any symptoms, so definitely that patient is infectious. Whether somebody who's, that's what we were talking about. Then you're talking about an asymptomatic person having a positive test. That's very rare, because many times we swab the patient by the time they become asymptomatic. So, but you take the history, he says, yes, I had a sore throat, I felt unwell for a day, next day it was ordinary, but then I got better. And that's when we have tested. And so often patients are symptomatic, but the degree of symptoms might differ, and many people won't even consider that as symptoms until we ask, or until CDCB calls and asks specific questions. So that's why I think New South Wales, there was a staff member who worked for 6 days in a nursing home, because according to that person, he or she had a mild sore throat the first few days. So that you can't say that person was asymptomatic, but that's what we would have done pre-COVID. And that's why many times we have long flu season, because we do this. And this year, our flu season is going to be much better, because we all learned what social distancing is, and that we need to stay at home if we got any symptoms. And so I think, I hope that explains the first part of the question. Then when somebody is in day 10 of the illness or day 14 of the illness, and you swab and they're asymptomatic for 5 days, and you swab and there is positivity, that what it just means is that we first of all don't know whether it is a live virus or a dead virus, or what is the level of sort of the viral load at that point in time. We can look at CT values, and that's what things become a bit more complicated when we look at a PCR test and we look at CT values and see how high it is. So that's a hole that we got into slightly in Flinders. We stood up this COVID clinic very early, and then we looked at cDNA guidelines. cDNA guidelines says 10 days from the day of onset of illness, plus 3 days of 72 hours of asymptomatic period. But we wanted an objective measure, And there are a few studies, small studies from Europe, which said that you can do swabs and give a clearance. But when we look at our cohort of patients, around 60 odd patients, 20% of them were still positive on day 15 to day 18. So that, and they'd been asymptomatic for some time, and that's a growing frustration. And that's when we reverted back to CDNA guidelines. And obviously there also was some confusion because we were doing something and the rest of the state were doing something else. So I think so it has to be taken into context. So if somebody is positive, then is on the tail end of that disease and is asymptomatic, then probably that person is not infectious. In fact, none of the family members have become positive after that period of time. So which again shows that hopefully that answers that question.
Yeah.
Or might be a confused.
No, I think that's great. I mean, Louise, what are your thoughts on that as well?
I did just want to say something about another reason why hopefully we'll have a low flu season is that we'll all go out and get vaccinated. So
if we have vaccine stock, if we have vaccine stock, is the other issue. That's another issue, a side issue, isn't it? The low private vaccine stock existing at the moment in general practice.
I just did want to say about the swabbing. So there is the CDNA guidelines, and we don't recommend you going swabbing someone who is already cleared because that is very confusing as to what does that mean. It might mean that it's dead virus and it's not relevant, but it does make it very hard to make that interpretation, and you then have to, it's confusing as to what that means. So if someone's already been cleared, there's no need to re-swab them, unless, of course, their illness has changed or whatever, and you think that they've you want to check for another virus or, that type of thing. But if someone, there's been no change in their clinical picture, there's no need to re-swab someone who's already been cleared.
Yeah, and I mean, I guess there's a lot of anxiety out there in the community, and maybe that comes down to the way we're messaging and sending out those messages that once you are cleared, it's okay to leave your house and go to the supermarket and do your shopping. Because Jenny, you've had so many patients come back who are just so anxious, have all developed basically PTSD type pictures.
Yeah, very anxious about leaving the home, and certainly a lot of mixed messages, and so confusion over what they're supposed to do. But turning up at their pharmacy in a country town and being refused entry, even though they've got a clearance certificate because it doesn't state on there that they've got a negative swab result, and so being refused to allowed to enter the pharmacy. Lots of stuff out there that just misinformation, but making people's experience just really, really traumatic. And really, I mean, even today, I had someone who turned up at one of the respiratory clinics, which was a misdirection, really. But she'd been cleared for more than 7 days. She was actually going back for a 7-day check and to volunteer for the research bloods. Then we were still doing those, and got re-swabbed. Clinic just re-swabbed her, and so now we're in this situation that she's already been cleared, returned to work, re-swabbed, feels like everything I told her before is wrong because she's been to this special place with a video screen that's told her she had to be re-swabbed. So we just endlessly are getting confused messages, and I think it's a really scary time for everybody. But when you're getting conflicting information, people don't know where to trust, and we're just voices at the end of the phone. I don't know how awesome we really are. That's it, Yeah.
We've had another question come through around dramatic worsening, and this is for you as well, Santosh, around have you seen anything dramatic happening in the community or patients in the community whose condition has deteriorated or anything like that? Or can you give us a bit of context on that?
Yeah, I think that's the reason why we closely monitor patients who are in the community. We have hospital at home, and GenWise has regular phone calls. So the dangerous period is from day 7 to day 11. It's a second week that the deterioration happens. Few markers are that if patients have a bloods done, if we in Flinders, if the patient is swabbed in Flinders, we still see them and do a baseline bloods. If you have lymphopenia, significant lymphopenia to start with, and a raised LDH, those are people who have potential to do worse. There are some scores which has now come out of Wuhan, but I don't believe in scores. I believe that clinically, if you look at a patient, you know whether somebody can worsen. Secondly, if somebody has persistent cough and is not getting better, you have to keep a close eye on those patients. They will have a cough which doesn't get worse. That there are some people who are cleared and with our criteria, but they still have a mild cough. That's not what I'm talking about. I'm talking about worsening cough. Then those are patients who need SATs taken, and you will be surprised to see that they drop saturation very, quickly, and they'll be looking well. Third is persistent fever. We have had quite a few patients who have had fever, settled by day 5, but there were 2 patients who continued to have fever, and that was the reason why we escalated the care, transferred the patient to Royal Adelaide, and the patient spent another 2 weeks in Royal Adelaide just because of. And when you look at the Wuhan literature that coming from Wuhan, those patients who were mounting fever, they were the ones who ended up in ARDS. They had a higher risk because of the cytokine cascade that was prolonged. I don't know. I was reading that Boris Johnson was febrile on day 10. He was admitted on day 11, I think, or on 10. So that's a marker to watch out for. So these are things which we need to as we all know, 85% of them by day 3, day 4, they're perfectly fine. And the reason why we started monitoring them closely was because some of them who are young will feel like, why they should stay for 14 days. But then this small subgroup of 10 to 15% can deteriorate in the second week.
And we just had another question around about low pulse oximetry as well, and that being a poor predictor. So, there's obviously lots of things we should be thinking about with these patients in the community to prevent deterioration. And I know that's something you've been working on, Jenny, as well, with your risk assessments to try and sort of control and make sure that we're picking up those early signs. We had another question around, another one for you as well, around a controlled contagion scenario. Yeah. So what are your thoughts on that? Yeah.
I think that's what Singapore was doing, but unfortunately they've had a second wave. So it's Sweden is an experiment still happening. We are not big fans of that particular model. That's not very controlled. But Singapore, yes. But now they've closed their schools. Their construction industry is almost shut down. So I think it has to be done. I think, again, South Korea stands out. I think they've been able to manage to keep the economy moving at the same time. And I think that's because these countries had experience with SARS-1. And secondly, the population, they traditionally wear masks, even when and they know how to look after. They don't fiddle around with their masks and contaminate themselves. Thirdly, all these populations in Southeast Asia, they're very responsive and to the healthcare advice that comes from the government and healthcare authorities. Since I think in Korea, if you flag positive, you get at least 4 text messages per day. And that's what and if you move out of the area that you live, you get a text message. So those sort of things doesn't work here. But I think in those sort of situations where patients are highly motivated and are responding to the health authorities, then probably there is some room for controlled sort of management of the epidemic. I think UK tried that in the beginning. I don't think it was controlled at all. So there is significant risk.
Thank you for that. I mean, that's a really interesting discussion. So I'm so glad you could provide that, because we often get questions like that. So it's wonderful to have all that context behind about what's been happening in all those other countries in the Sweden experiment. Chris is going to give us just a bit of an update of things as well.
Just a quick, the usual potpourri of things. Can you hear me at the moment? I'm away from the... Okay, cool. So the first thing is I'm going to point you back to Health Pathways SA. There's an easy login now. It actually automatically goes in from the portal site. The reason why is all the links that I'm going to put into from today, I'll put in the next couple of days. So the things I'll be talking about is all the Medicare changes and stuff that's been negotiated. So the big thing that you've probably heard over the last couple of days is the new bulk billing incentive with respect to that gap group, because previously we had the groups that had the bulk billing incentive for those people who had were pensioners and under 16s, and then we were allowed to privately bill patients who were outside of that, but we weren't allowed to privately bill the individuals who were in certain vulnerable groups. So as you recall, last time we were working towards getting a bulk billing incentive for that at least, and so that has come into being. And now there's a couple of new bulk billing incentive item numbers can apply to them. Now, what does this mean? It's a vulnerable patient means that at risk of COVID-19. So you see on there, it's basically those under the AHPPC committee that need to self-isolate, self-quarantine, at least 70, identified as Aboriginal Torres Strait Islander, is at least 50 years old, is pregnant, is a parent of a child under 12 months, is being treated for a chronic condition, is immune compromised, or meets the current triage protocol criteria for suspected COVID. Now, the relevant one there is the chronic health condition, and that is a condition that has been there, was likely present for at least 6 months, was terminal. Basically, it does cover all bases. You end up either, you have the choice to either privately bill, but you have to make a clinical decision about the chronic disease, chronic health condition, and I think I would refer to the site, and I'll send you off the link to that at some stage on the Health Pathways site. I think it's already been sent out by Emily's email as well. Yeah, look, don't give me every question about what it constitutes. You just need to actually be fair about what a chronic disease that would affect, be fair. I think you have to look at your own heart there. So please don't ask me every condition. It's really up to you. You do need to use discretion and, be fair about it. So they're the items, 10981 and 10982, depending on whether you're in the metropolitan area or not. E-prescribing, so we'll send you the two bits of paper now. There's one, the national one, but there's also a local one. And the reason why is the summary of these is, and we'll send you the links for them, because in South Australia, we've actually got basically two parallel systems. And the main issue, as you recall last time, was to get away from the need to send the actual signed prescription to the pharmacy. So now we have this under national special arrangements, which only go until 30th of September. This is for all scripts except for SA or S4s. Some S4s, including benzos. You can fax, email, or text an image of the signed script to the pharmacy, and then you have to keep it for two years, this original signed script. I know people are complaining about the two. Look, hopefully this will be over in a month. We're going to get proper e-prescribing. So can you just get over it? We're actually working really hard on this. Okay, you're going to have to keep a few of them. Okay, so just relax, because there's the other option if you don't want to do that, which is for all scripts, including S4 and S8. So this is this get out of jail free for S4 and S8s. You can fax or e-fax the image only. You cannot text or email these of the signed script of the pharmacy, and you have to have on there the dispensing pharmacy named on the script. And if that gets to there, you don't have to send it, and that script will be on it, and you don't. So that's the get out of jail free. And if you don't want to use email and text, you can use that method, and you won't have to keep it for 2 years. Okay.
I can't believe that's been in the legislation for years.
Yeah.
Chris.
Oh, well, no, there was also the other PBS requirement, though. That was a separate issue. So that was one. Okay, so if you want to take a screenshot of that, we'll send that to you. Medical fitness to drive. Now, about a month ago, as you recall, I got them to negotiate it so there was a hold on all medicals essentially, except for those people we had to take off the road for common sense reasons. There's been a change now, so they're back down from that a little bit. So they've done a risk assessment and said that basically licence holders with the MR, HR, HC or MC, which are, I think, are the heavier licences, they will need to have their, that have a medical condition, they will need to have their licences renewed. Those who are driver accreditation holders with a medical condition, God forbid, not too many of those, and licence holders who have a medical condition of the South Australian Police who are advised not medically fit to drive, they will need to have them. But the licence holders of the normal vehicles have been extended for 6 months, and licence holders with medical condition with normal have been extended by 12 months. So all those over 70 Class C, 75 years, will have their extended for 12 months. So it's a lot simpler at the moment. So yeah, basically it means that the higher risk, heavier vehicle ones, they will have to have their medicals done. So there's been a slight reduction in that, but it makes sense. Now, can I just make a comment? And I'm the chair of the Ethics and Medical Legal Committee federally. So one of the issues about medical certificates for vulnerable workers, we're getting a lot of organisations are getting some, let's be frank, inappropriate medical certificates. So we've seen medical certificates go to them, and they are getting a medical certificate saying this patient has a medical condition, and because of COVID, they can only work 2 hours a week and at the work, and they should own, like, it just doesn't make sense. It's conflating a whole number of issues. So what I would say to you, and we're coming out with some guidance on this, your job is really not to actually, as far as vulnerable workers, this is your job is not to determine what or not they can do unless they've actually got a specific medical condition. Your job is actually declare whether they actually can fulfill the criteria under AHPPC as a vulnerable worker, and that's very clear, and it's on this website, which we'll send out to you. I don't think you should be going out there and, you should basically either write a letter or medical certificate stating the patient's fulfills that condition, but you don't go telling the employers what they can do, because it's really up to the employer to decide how they will take that up, because it's really not technically a medical condition. It's a risk condition. It's not a medical condition. Now, if they've got a separate medical condition where they've injured their back and blah, 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 that's different. And you may give an opinion about that. But what I would say to you is be very careful about what you're writing on the certificates, because your job is to actually declare them as they fit under the vulnerable workers criteria, not to actually necessarily just micromanage and tell the employers what to do under the circumstances. The final thing is, can I just say, this is a personal thing that we've had. We've had a lot of complaints, and I'm afraid we're pretty unhappy about this. So what's been happening is we've had this complaint for the same practice, unfortunately, about the practice which is closed and not doing any face-to-face. And then what's actually happened is they haven't actually left a phone number which is actually usable, and they haven't been answering any of their messages, even though they said they would. And we've had this distressing thing where this man called, was extremely distressed. He had severe disabilities, walked 3 kilometres to the practice because he couldn't get an answer from them after leaving numerous messages. He does not have a computer to contact them online. The place was shut. There was no message on the phone, and this is a message on the website. And it was just, look, all I can say is, I personally and various groups have busted our guts to try and get telehealth to reduce the safety for us and our patients. But can I say to you that, we do need to actually consider the needs of our patients as well. And there is a role definitely for face-to-face still, and to make sure that patients, we actually do an obligation, we have a professional duty to make sure that patients have, whether we support our patients if they, they're not left abandoned in this situation. So can I just please ask you to think about what your entry points to your practice are, because, this sort of thing isn't actually, we're getting a lot of complaints along this line. So, just have a think about where it is, please. It doesn't reflect well on us. We've done such a great group, and I suspect all of the people on the line are the ones who've been doing a great thing, but it doesn't reflect well on us.
And that's an interesting point as well, and to raise as well around returning to work as well, Chris. We sent out some information about that yesterday, about the importance of involving return to work SA. If you do have any concerns for your patients going back to work after they've tested positive for COVID and then have been cleared, so just to keep that in mind, that they're there to support you, and you could have a chat with their claims manager as well if you've got any concerns. And just as Chris mentioned as well, the other option is for GPs who don't have access to PPE, and I do understand there are a lot of PPE shortages. Adelaide PHN has been trying to work through those shortages this week because we've noticed quite a big drop in our PPE supplies. There is the option that you can refer to the priority care centres as well, who are happy to see patients from general practice, so they can be referred. And we sent out information about that a couple of weeks ago, but it'll be uploaded onto the website soon as well to make that easier for you to know how to refer your patients. Now, I do apologise, there's probably been a few other questions that have come through on our chat box, but Chris has had my computer, so I haven't been able to see the questions, Chris. So what I'm just going to do is stop the screen share there and just have a quick look through and just go through the last questions, if that's all right. Sorry, we're going a little bit over time. So we had a question that came through around nursing home attendances, and so say, for instance, a patient goes to radiology or a dental appointment, can they then come back to the nursing home on the same day, or are they required to isolate and quarantine for 14 days even though they're asymptomatic? And the answer to that is that they can come back into the nursing home. There's special provisions around that. And there's also been a specific new direction that came out last night around aged care visitation rights as well. So those patients can certainly go back in. If they are a resident of that nursing home, they can go back and they don't need to isolate. And then we had another question that came through. Actually, there's been a couple here around pneumonia in COVID, and a little bit about, what are your thoughts around why usual treatments for ARDS are not working, and, are there any thoughts around what is really happening in the lungs and concerns from a respiratory point of view? So I don't know if you wanted to talk about that at all. Any thoughts on that? Is it just that we know this is it's such a bizarre virus that does strange things, or what are your thoughts? What are your technical thoughts on that, rather than does strange things comment from me?
Bizarre.
I'll start off saying that I'm not an ICU physician, nor am I a respiratory physician, but I think ARDS doesn't have any treatment, actually, unfortunately, and especially in COVID, there's no benefit of steroids in these group of patients. I think IDSA has brought out the treatment guidelines, and it's very clear that only in a trial setting should that be given. Tocilizumab had been tried, and it is not worked, and probably adverse effects are much more. And according to the guidelines, it says only in a trial setup it should be used. So there is not much that can be done except the immune function of the patient, and patients who have got more comorbidities, who's got underlying lung disease, are the ones who do badly. So that's all I can say. I can't go into the pathophysiology of it, unfortunately. I don't know.
Yeah, and I mean it's just so uncertain, isn't it, about whether a vaccine will be developed or not. We've heard of different trials happening, but is there any comments at all from the group around vaccine status and lifting restrictions as well, and whether we might see that happening by the end of the year? Tough.
Too early to comment, isn't it, really?
Yeah, I'm quite pessimistic, unfortunately, because first of all, there has never been a vaccine for a coronavirus. Secondly, Anthony Fauci, who's an immunologist and ID physician, who's mainly heading the COVID response in US, he's an authority in this area. One of those people who got dual qualification, and those of you who have read Harrison will know that he's been one of the editors of Harrison's textbook for many years. So he feels that the antibody response is very poor, and he has put some serious questions. He's even gone to the extent says we might not have. But on the other hand, Oxford University, Oxford has just announced that they've got 2 vaccines coming out, and one they're starting human trials this end of this week. So that will be very keenly sort of followed. Israelis from Israel, they have a vaccine in the making, and what I heard is that Flinders Uni has a vaccine which they've been working on SARS-1 for some time, and so there are quite a few vaccines in the pipeline, but it's early days, as John mentioned.
Yeah, look, I think this has just been such an informative webinar. I'm so pleased that we could have you here tonight as well, bringing your ID perspective, Santosh, as well. And thank you so much to our regular guest panelists coming in. I had the RACGP had a meeting with the Health Minister today, and he brought up about these webinars, which I thought was really nice, and said how fantastic it's been that we've had so many GPs who have been engaged with these webinars. And I'm just so grateful to everyone who has come along, and to Adelaide PHN for allowing us to host this, and for publicising the webinar as well, to Tom, to you Louise, to you Chris, Jenny coming along tonight, Danny, who has empty seat over there, is not here, and to you Santosh as well. So thank you so much. As always, very happy to have questions emailed through to us, and we can send them as well through to you, Santosh, if there's specific ones, if you're happy with that, along with all the referrals that you'll now be receiving through through the SALA network. So thank you so much, and we wish everyone a good evening. Thank you.
Thank you.
Good night.